Good afternoon, everyone. Welcome to Project Open's Tuesday Talk. Project Open, as you know, is a federally funded substance use disorder grant, and it focuses on helping people with treatment, recovery, and prevention from addiction to opioids and other substances. So I am really happy. Today's talk will be focused on discussing treatment and prevention options. Today, I'm super excited that we have he is an anesthesiologist and interventional pain physician, speaking to us about how to manage your pain. And Dr. Kothawala is part of our KSB family in Dixon, Illinois. Welcome, Dr. Kothawala.
Thank you. Thanks for having me.
So today's talk is titled, What Role Should Opioids Play in Managing My Pain? And the reason we have this as a topic is because we know that opioids are an important part of pain management, and at the same time try and understand really what other options do we have. So I know many of us are suffering in our community from pain. I have personally, Dr. Kothawala, had chronic back pain for several years and have used almost all pain management options. So I've been blessed, though, to have a healthy back now, thanks to all the wonderful doctors and therapists that have helped me through my journey. So wanted you to have that background. So to start us off, Dr. Kothawala, most of us who are in pain are going to be speaking to our primary care doctors about our pain, right? That's where we'll start. So the first question I had for you is how do I talk to my doctor? What would you tell our patients and our listeners? How do I talk to my doctor about my pain, and what should I expect from my doctor in what they may do to understand the cause of my pain and how to manage it?
Yeah, that's a great question. And first of all, I appreciate you kind of being so forthcoming about your own personal history, because I think it helps for everyone listening. I think, probably everyone's situation is going to be slightly different, but just as you did, don't be afraid to bring it up with your doctor. The fact that you've been suffering with pain, and maybe even before that appointment, you can kind of mentally keep track of certain things. So for example, how long the pain's been going on, where you feel it exactly, whether it radiates anywhere, what things make it better or worse, what things you've already tried. All of that information will be useful for your doctor or your provider to try to figure out what could be the possible culprit for your pain, and also then what might need to be done, at least initially. So part of that initial process will probably involve some degree of a workup. You might get some x-rays, for example. There's a chance that your doctor may suggest physical therapy or possibly seeing a specialist related to the area that you're hurting at. And so sometimes it can be a little bit frustrating for people who are suffering from pain that, it seems to be several visits and appointments and diagnostic studies before they're started to, getting some answers. But all this is important because if we can get a good diagnosis of why you're having the pain, then we can treat it most effectively. I know one of the goals for Project Open is to touch upon opioids and safe use of opioids. And I understand we'll be talking about that to great depth today. But one of the things I guess I wanted to touch on right from the get-go is that your doctor may suggest certain medications to try to get the pain under control that may or may not involve opioid medications. But even if your doctor discourages opioids or doesn't want to start you on them, understand that it's not because your doctor is unsympathetic or doesn't believe that you're in pain or doesn't want your pain to get better, but it's because of a number of topics that I hope we'll touch on today where through experience and a lot of studies, we found that maybe opioids aren't as benign as we thought, and that they do have some risk involved with them. I think that's pretty much the most of it in terms of like initially bringing it up with your primary care. You can always kind of keep them updated too. If, say, for example, if it's a topic that you've addressed in the past, but you feel like your pain's getting worse or really interfering with your quality of life, there's a variety of things that, they might be able to kind of suggest. Even if you think that you've tried everything in the past, there may be new things out there.
Yeah, that's a very wonderful answer, Dr. Kothawala. My personal journey again was a long one. It was about it was 9 months really of going through sort of trying to figure out that initial piece. It's like what is causing it, and what did really help in my physician was basically keeping a good track of that, keeping a diary, right, for the pain, and where is it, when is it, what's making it worse, what makes it better, how long has it been going on, and so on and so forth, and what have I tried, and it was a long process, and it was to an extent frustrating initially, and I'm a physician, so I should know the process. And so for our listeners, I think it's important to just remember, like Dr. Kothawala said, is just stick with it, and it's a step-by-step process that our doctors are doing to try and get to the right place and getting the right tests and so on and so forth done. There's not really one simple test to do to figure everything out and then and then get to the right place. So appreciate that.
And actually, just to cut in, just to emphasize on that point, and the frustrations that unfortunately a lot of people go through is that in terms of the test, sometimes it's easy. Sometimes like you'll have certain pain and right away, someone will know what it is. And other times, for example, one of the most common conditions I treat is low back pain. And even if you get MRIs and if you've got EMG nerve conduction studies and everything, it might give us a lot of good information in terms of what structurally might be not quite normal, but it doesn't conclusively tell us that certain thing that we see on the MRI is causing our pain, or if it's a combination of different things. And so that can be, I think sometimes be one of the most frustrating things is that, okay, I've gotten one study after another, and now you're telling me I need to try this injection, or I need to try physical therapy, and so all of that, kind of stick with it, and hopefully, kind of like in your case, Dr. Nag, you'll have a good outcome, and at the very least, hopefully you'll get to a place where the pain is tolerable and it allows you to function. That's one of the main endpoints that we're going for.
Yes, that's wonderful. Thank you so much for sharing that. I think it's important for everyone just to know that it's a long journey, and to be patient, and your doctors and everyone and your providers are really trying to work step by step, try and get you to the right place. So Dr. Kothawala, can you speak to us about opioid medications in general? What are they, and when is a good choice for us to use opioid medications and durations, etc.?
Yeah. So opioid medications in some form or another have been around for quite some time. Obviously, they're derived from opium, and then we had several different opioids, which are just kind of essentially derivatives of it. So morphine, and you've probably heard of many other medications like Dilaudid or oxycodone, hydrocodone, fentanyl, sufentanil. Heroin is also kind of in that same family, I would say, although it's not used, at least in the U.S., for legitimate reasons or for pain control. These opioid medications are very effective and some of the strongest analgesic medications we have. They can help for a variety of different pains. So whether it's kind of like a pain after an injury or chronic pain from a nerve that's irritated or what have you. And most of them are medications that don't put stress on your kidneys or your liver, don't put you at risk for stomach ulcers. And so in some regard, they're better tolerated for certain medical conditions. Yet, the history of it is a little bit interesting. What these medications were very commonly prescribed for chronic pain, up until say a decade or two ago, and actually even more recently than that. But we've kind of found over time, as I mentioned earlier, that there are side effects and risks with these medications that we didn't really appreciate the amount and the extent to them, and not to mention kind of the societal concerns, which I know Project Open, that's one of the concerns that they're trying to address. And so these are medications now that we realize are probably not quite as effective in the long term as we thought, and also definitely do have some risks and side effects of their own that need serious consideration before we even start a patient on them or decide to continue and make adjustments and things of that nature. Do you want a little bit more detail than that?
Yes, I think that would be very helpful for our listeners. I think, what are some of these risks, right? And then if you can talk about, the opioid pandemic and how what are the things that kind of led up to that pandemic. But just to start with the risks a little bit more, and then going into the pandemic that we're having with opioid addiction.
Okay, yeah, I think that sounds good. So there's, just like any medication, there's a variety of different risks or side effects that you can get with these opioid medications. One of the most common that we worry about is some degree of fatigue or over sedation, drowsiness, potentially some dizziness. You can get others like nausea. Constipation is a big one. And it's one that even over time, some of the side effects your body gets used to, but constipation, it does not seem to, and it can just kind of progressively get worse. And there's some other ones where it may reduce sex drive or lead to erectile dysfunction. You can get urinary difficulties with it. And it can potentially affect your mood to some extent. One of the big ones that we worry about is that it can affect your breathing and slow down your breathing. I mean, you hear all the time on the news, for example, people kind of overdosing and stop, like, either slowing down or stopping their breathing because of, say, accidentally taking more than they probably should have been taking, or potentially using, say, heroin or fentanyl or something like that. So those are some of the risks and side effects with these medications. The breathing one is also of import because some people might have underlying respiratory issues, say, for example, COPD or obstructive sleep apnea, that put them at added risk. And even if they don't necessarily stop breathing per se, they can slow down enough that, for example, it may lead to higher carbon dioxide levels in their bloodstream, and therefore maybe more strain on their heart, and a whole cascade of issues that might potentially put them at heart failure, etc. So those are some of the risks and side effects. There's obviously other ones. One of them that we know almost universally, meaning almost everyone to some extent gets used to these medications, gets something called opioid tolerance, where over time it just seems that the opioid medication that you are on just gets less and less helpful for your pain. And so that's kind of, if that happens to you, then the question is, okay, should we try something else maybe instead, or in addition? In very certain situations, maybe, you can try a different opioid or increasing it, but, there's obviously some concerns with that as well. Opioid medications are very addictive too. And so there is a big concern in that regard, that someone who maybe doesn't have a history of any substance abuse issues, who's never been addicted to anything, maybe doesn't even smoke or any of that kind of stuff, has been prescribed an opioid medication for completely legitimate reasons. Say, for example, they had a minor surgery, or they had a tooth pulled, or what have you, and they were put on just a short term of opioid medications. And that's caused them to become addicted to these opioid medications. And it's just unfortunately kind of a downward spiral in that regard too, sometimes. I would say one of the risks with being prescribed opioid medications also is that there's some risk to family too. For example, if you have this medication in your medicine cabinet, and it's not locked up, there's a chance that anyone from a spouse or a child could get into it, and not only get into it and use it for themselves, but potentially become addicted to it, or get into issues where they try to sell them at school or what have you. We've even had situations where we've had elderly patients and their adult children are kind of just using them for themselves and just giving their elderly parents, some other pill like Tylenol or what have you, and then, complaining that their parents aren't, they don't have good pain control. And then finally, there's a whole host of other risks and side effects with these medications that actually are not very well known. And there's probably some research more to be done on this. Some of this is based on animal studies. But for example, we know clearly that it affects everything from different hormonal levels. So for men, it can decrease testosterone levels, which secondarily may be one of the reasons for people maybe having decreased drive and ED and things of that nature. In women, decreased progesterone and estrogen levels, along with some other hormonal changes. We know that it can affect your immune system and decrease your immune system's ability to fight off infections. And it can decrease cortisol levels. We know that it leads to higher rates of depression, interestingly, because a lot of people would think that if you're in chronic pain and you're in depression because of it, potentially, that if you were to put someone on strong pain medications like opioids, that their depression would be improved. But in fact, it's unfortunately oftentimes the opposite. And in fact, there's some studies that have actually demonstrated that patients are at higher risk of suicide too if they're chronically on opioids. So these are all, these are all kind of significant concerns that we have with the use of opioid medications. I think you also asked about maybe like the background of opioids and kind of how the opioid epidemic, is that?
Yeah. Do you have some, actually, just to recap a little bit of the information that you said, that was amazing, just to kind of hear about all those side effects, and some of these things I forget, and it's, there's obviously a lot of different options, and I came across some of those in my own journey, but we'll get to that next. What's your thought? I've heard this, the impact of the fifth vital sign. We were doing that, the pain score, right?
Yeah.
And the impact of basically, prescription opioids being given out to many, and so on and so forth. Can you give me your thought on basically how do you think those things played into the opioid epidemic?
Yeah, that's a great question. So, yeah, I think it's the majority of us at this point are in agreement that probably a lot of this was a confluence of factors that include, it was kind of around the mid 90s, if I remember correctly, around 1996, that the American Pain Society, realistically, both in the pediatric and the adult population, we probably had been under-treating pain. And at the very least, not in a systematic manner, meaning some people, if they had pain, it was being addressed and assessed, but other people it wasn't. And so there was this need and legitimate concern that we need to do a better job of assessing people's pain and treating it effectively. And so, the American Pain Society lobbied to try to, they had this campaign called Pain is the Fifth Vital Sign, in order to try to improve a kind of uniform assessment of patients and their pain levels, and therefore then secondarily, hopefully treat it more effectively. And it was quite popular, and it really caught on by a lot of medical societies, by regulatory agencies, by pharmaceutical companies, eventually by hospital systems, and even the Centers for Medicare and Medicaid Services, or CMS. It was thought that they at least implicitly were kind of enforcing this, or at least agreeing with this as well, because there's, and Dr. Nag, you obviously know this quite well, but the HCAP studies or surveys, these are surveys that are given to patients about many things, but including about their hospitalization and how their treatment was with their physicians. But it's interesting because it's not just a survey that just kind of, there's a lot of kind of importance to it, because it's tied to reimbursement for the hospitals too. And at least one or two of the questions were really assessing, I think the question was something along lines of, I think, how frequently did your provider or hospital try to do everything in their power to address your pain or something to that
Right.
regard.
Exactly.
And so there was, a lot of pressure on physicians and other providers to do their utmost to try to get patients' pain under control. And keep in mind, like you alluded to, Dr. Nag, the measurement tool that we're using for this, pain is obviously, there's no objective way to kind of measure your pain scores and your intensity, and it's all kind of self-reported. And so we had used these very unidimensional assessment tools, like how bad is your pain on a scale of 0 to 10, or like you guys have probably all seen kind of these smiley faces going all the way down to like the frowny face, and kind of picking something in between for how bad your pain was. And so, this was a lot of pressure to try to treat pain as aggressively as possible. And yet at the same time, or kind of maybe just shortly thereafter, kind of when this push initially started, there was a little bit of a push from certain pharmaceutical companies. For example, Oxycontin came out, and Purdue was really marketing it as not only an effective analgesic, but one that was non-addictive and not habit forming, and also something that was abuse deterrent, or at least was very difficult to abuse. It turned out that that was not at all the case. And so, you had these situations, for example, where you might have a well-meaning physician who sees many patients a day, each of them having many medical problems, and some of them that really need to be addressed. But then in addition, is kind of saying, oh, by the way, I also have this kind of pain. It's still bothering me. And you've already worked it up. It's kind of a benign pain, but it's obviously, significant. Well, okay, go ahead and try this medication. And really, even in the world of pain management, the thought process at that time was that, okay, these are relatively benign medications, as long as they're not going to overdose on them, and they don't have breathing issues or what have you, and their constipation is under control. And even if they become tolerant to it, well, we just go up on the dose, and then later on we go up on the dose even further. But what we did find was that, for example, Oxycontin was very easy to abuse, and a very potent analgesic medication. Just as a frame of reference, it's more potent than morphine. And so then we had all these people who essentially were being prescribed these medications that are clearly gateway, or at least potential gateways, to kind of either opioid addiction, or possibly even kind of harder drugs. It's a whole nother thing, where then the pendulum kind of swung back the other way, and we're trying to curb opioid prescribing. But some people, either with addiction that's not being kind of managed effectively in other ways, or people with chronic pain that's not being managed, then unfortunately kind of went to other sources like heroin and what have you. So all of these factors played a role. There's many others. There were some bad apples that were either being influenced too much by maybe, say, pharmaceutical companies, or that ran pill mills or what have you. But I would say at least those few things were probably, at least from my understanding, the biggest contributors to the opioid epidemic. And now obviously we're trying to rectify that. But you have to understand, between 1999 to about 2013, the number of opioid overdoses from prescription opioids quadrupled in less than a 15-year period, and this was just a slope that was just, I should go this way. It just was continuing to trend up. And subsequently, we saw that maybe it was potentially leveling off. But what we saw, unfortunately, was that then a lot of these people were then shifting over to harder drugs like heroin and fentanyl being imported from overseas and what have you. So I think that's kind of, I don't know if that does an adequate job of kind of, I think, painting the whole picture. So now there's understandably some pressure on prescribers to try to do things, in as a safe manner as possible. And then part of it also is that over time, with this, with these medications being out for longer, as I alluded to earlier, we've also gained a better understanding that these are not as benign as I kind of mentioned. And additionally, there have been many studies out that seem to demonstrate that the benefit that we thought that they gave maybe isn't quite as robust as we thought. For a lot of different pain conditions, It's that perhaps it doesn't actually improve your quality of life in terms of any sort of objective measurement. So, for example, your functional level, there's a lot of people who, might feel that, yeah, this allows me to function and be more active. But yet when we look at large scale studies, and we've looked at how much people were doing before and after initiation of opioid therapy, it hasn't really changed, unfortunately. And additionally, even the pain scores that they report before and after hasn't really changed. So it's kind of one of those things where we have a better understanding that there's greater risks than we anticipated. And the benefit maybe hasn't quite manifested, although obviously every case is different, every patient is unique. And so this is something where you talk to your doctor about what your situation might entail. But in general, it's led us to kind of take a step back and really look a little bit more carefully before we at least initiate someone on opioid therapy.
Yeah, that was a great summary. Thank you, Dr. Kothawala. I mean, it is, we're learning as humans, right? And we're learning about opioid medications, pain scores and pain scales, and mandating those. And now we've learned that those have actually caused more harm maybe than good. And so now we're adjusting. Now we have good pain management guidelines, which have come out of that, as you, I'm sure, use, and the doctors use. They have more evidence around what to use and so on and so forth. So there's better. We're learning is is how I see it. And it's amazing. The amount of information that you shared was really, really awesome. So I remember that, from my own experience with pain, and what I had was eventually, a herniated disc, basically, which was shooting pain and numbness down my left leg, and did a lot of different pain management strategies to help, which were not opioids. I remember not really being on opioids so much till just for the first few days after I had to have surgery eventually. So can you discuss some of these options for pain management? What is available locally, just to highlight that too for our community members? Things that I'm thinking about, like other medications that are not opioids, then maybe physical therapies, and then the psychological tools that we have, in addition to what you do best, which is also the advanced interventional pain management pieces. So.
Yeah, no, I'd be happy to. And actually, I think, Dr. Nag, you're probably referring to like the CDC guidelines that came out, I think, in the early 2000s. I can't remember the exact year, but yeah, so there were the CDC put out guidelines or recommendations for physicians, especially primary care physicians, to kind of essentially utilize safe prescribing of opioid medications. And it's interesting because they actually hit on some of what you were referring to in terms of, well, it's not just a matter of that opioids are higher risk and they haven't clearly been shown to be as helpful as we thought, but then there's also other alternatives that are maybe just as effective, if not more, and also are potentially a lot safer, and at least for certain patients. And so there's a wide variety of other treatment options, and they're not mutually exclusive. So you just as you indicated, Dr. Nag, you may potentially, for example, physical therapy, you may do that, but in addition, try certain other medications and what have you. So even just, for example, the topic of physical therapy, I almost universally recommend physical therapy for my patients. No matter the cause of their pain, because it can be helpful for a variety of ways. I mean, when you see a physical therapist, it's a specialist that can help you with kind of understanding your body mechanics and figuring out potentially a cause of your pain, but then also help you in a variety of ways, including strengthening, improving flexibility, and also minimizing or reducing fear avoidance behavior and maybe helping you overcome that. And coming up, one of the main things I stress with patients is that if you can come up with a home exercise program that you can do even just 5 to 10 minutes a day most days, that will go a very long way to kind of help decrease further deterioration, for example, say in a lumbar spine issue, and to keep you active and mobile and functional throughout the years, and that's something that's entirely within your power. There's a whole host of other medications, starting out from simple anti-inflammatory medications that you can get over the counter to prescription strength ones. If your doctor feels that you don't have any contraindications or reasons why you may want to avoid those. There's nerve pain medications, if you will, or neuropathic agents that generally fall into two families. So common ones are, for example, gabapentin or pregabalin, but there's others that are kind of more almost in the antidepressant family that are used for nerve pain, like amitriptyline, nortriptyline, duloxetine. So a variety of different medications that can help not just actually for nerve pain, but for musculoskeletal pain, for myofascial pain, for fibromyalgia, really for a wide variety of pains. There's muscle relaxants that can sometimes be helpful in certain situations. There's a few other kind of analgesic medications that are non-opioid medications that could potentially be helpful either in the short term or long term. You touched on psychological therapies, which I think have been demonstrated time and time again with many studies to be quite helpful. Unfortunately, there's a little bit of a stigma associated with it. I hope to maybe dispel some of that today, but then there's also a big roadblock in terms of just availability in most of the places that I practice, including kind of like Rockford and Belvedere, Rochelle. There's, as far as I know, limited availability, but KSB Dixon is very unique that we actually have people available for this. But kind of going back to an overview of psychological therapies, in my mind, there's two components to this. So we know a large percentage of people who suffer from chronic pain also suffer from major depressive disorder or some degree of generalized anxiety or possibly catastrophizing traits or other psychological issues that they're going through. To some extent, it's kind of like a chicken or egg phenomenon where, it's understandable. If you're suffering from pain, severe debilitating pain, day in and day out, you can't sleep, it's affecting your mood, it's affecting your relationships with your family, it's affecting kind of what you can do, especially if it's bad enough where then it's affected your ability to earn a living, and possibly your identity and all of that kind of stuff. It can have a huge impact on your morale, on your mood, and can lead to depression. But we also know that someone who maybe did not have any pain issues, who had been suffering from chronic depression, especially if that depression is not well managed, can then deal with chronic pain or develop it almost secondarily. And part of it is just, anyone knows that if you have a pain that you're dealing with and your mood is pretty good, then it doesn't seem to bother you as much. But when you're really down about something or worried about something, it just seems to kind of really kind of take a little bit more of a toll on you. So that's one component where essentially if you have a person who suffers from chronic pain, but they also suffer from, say, for example, major depressive disorder that is not well managed or well controlled, no matter what, for example, me as a pain specialist, no matter what I try to do to kind of control your pain, we're not going to be able to make major headway until we also control your depression or at least start treatment for it. So that's one aspect. But even in someone who's not dealing with, say, poorly controlled depression or anxiety or any of those kind of psychological issues, there are psychological therapies or treatments that are quite effective in helping you with your pain and specifically helping you with the toll that your pain puts on you and the effect that it has on you. And so there's things like cognitive behavioral therapy, mindfulness and meditation, which are two separate things. There's biofeedback. There's a variety of different psychological therapies that range from being able to disconnect this kind of input that you have through your nerves and the effect and the impact that it has on your well-being. But then there's also things that you can do where you can actually teach your body to have control over certain processes that have been found to be very effective. And so these are things that once you go through them and learn how to do them, which takes a little bit of work. But especially if you're suffering from chronic pain that you anticipate you're gonna have to live with to some extent for years, if not the rest of your life, it can be very effective. And so I think, Dr. Nag, you've got pulled up here. Basically, one of the things that I'm most excited about and that I alluded to a few minutes ago is that KSB in Dixon is unique in that we actually have a psychologist, Dr. Heffelfinger, who is experienced in treating people with chronic pain, and actually is starting up this group therapy session for people who might be interested who suffer from chronic pain, to kind of go over this and a lot of other things that again have scientific evidence demonstrating their benefit. And unlike medications, unlike injections, I mean, there's really no physical risk with this type of thing. And so it's something that it's one of these very effective treatment tools that I know, and even for my training, I know are quite effective, but I'd been kind of limiting in offering my patients. I'd literally, up until Dr. Heffelfinger offered this, we're telling patients, well, perhaps, there's apps you can download on your phone, which still might be helpful, but it doesn't replace being able to talk to someone one-on-one and in person. And so this is something I'd encourage anyone who might be listening to kind of maybe jot this number down and call their office and see if you're a good candidate, or talk to your provider, especially if they're associated with KSB, to see if that's like a referral that they can make. And again, this is something we're doing, meaning pain management at KSB is doing in conjunction with her clinic. I guess, you touched on interventional pain too. So there's certain things that we can do to help with pain, especially on the chronic pain side. A lot of it, for example, we might do injections of certain areas where we feel the pain is emanating from. We can, for example, if there's, we think that it's indirectly or directly because of inflammation there, we can do steroid injections there. Sometimes we can do nerve blocks if we think certain nerves are the culprit. Other times we can do something called ablations, for example, radiofrequency ablations, where we, in a sense, burn off those small nerves. They're very helpful, for example, for certain joint-related pains, including arthritis of your back or maybe your knee or what have you, for people who have not responded to other therapies. So essentially, a lot of it is to kind of either decrease inflammation of very specific regions or to block pain signals from specific regions of the body. And then there's more involved things that we can also offer, including something called, for example, spinal cord stimulation that helps to modulate or dampen down your perception of pain signals that are coming from different areas of the body. And there's a variety of other kind of potential interventions that we might be able to offer. If nothing else, we're also set up for possibly kind of prescribing other medications that perhaps your primary care just kind of wants a specialist on board to manage. And so that's also available in Dixon too, as you mentioned.
Yeah. Dr. Kothawala, this is so amazing. You highlighted so many important things. Sticking with the physical therapy, having a home stretching program, and those things have actually helped me a lot, even post-surgery, post-ablation. I actually had to have ablation for a different reason, but still it goes back to some of the basics of doing the stretching and having those physical therapy and so on and so forth. And I really appreciate you highlighting Dr. Heffelfinger's work. I think that's, she has a lot of years of experience in pain management, and she's really good with working with clients who have chronic pain and biofeedback, and is very, very, very helpful. So, and thank you for sharing your wonderful thoughts of what you do as an advanced interventional pain specialist. We're really lucky to have you at KSB, and just appreciate working with you. So I hope everyone you got some of the highlights on basically how to talk to your physicians and providers in terms of your pain, how to sort of stick through the process. Sometimes it's a longer process to get to where you are able to live with your pain or live without pain. And then, the role of opioids. I think that was very wonderfully done, Dr. Kothawala. Thank you. And the side effects and the epidemic and the pandemic that's going on with opioids, and really understanding that, safe behaviors. If you have too much opioids and so on and so forth in your house, just go ahead and return it back to your pharmacy. I have friends who do that actually, because they need it for it now and then they'll go return whatever extra they have, so that other family members are not getting into it and it's not getting into the wrong hands and so on and so forth. So really a lot of wonderful information. Thank you so much, Dr. Kothawala,
No, thanks for
for
having me.
being in the program. I know you're busy, so thank you.
No, thank you for having me. And I really appreciate everything that you guys are doing, especially with Project Open and for the community at large.
Yes, thank you very much. Well, have a good day, everyone. And if you have missed the live session, it's recorded and then available on Facebook and YouTube.